this is Jamie from Aptekisic. I am going to be going through one of the chronic diseases that students in your classroom may be diagnosed with. Asthma is more common in children than adults and is the leading chronic disease in children. Currently, there are about 6.2 million children under the age of 18 with asthma. Asthma is the top reason for missed school days. In 2013, about 13.8 million missed school days were reported due to asthma. Students with asthma have a chronic lung condition that causes their airways to become smaller or narrower due to underlying inflammation or swelling, increased mucus production, and contraction of muscles around the airways or bronchospasm. The ongoing inflammation causes airways to be extra sensitive or twitchy. Remember, asthma is different for everyone. Symptoms or combination of symptoms you may notice include coughing, wheezing, chest tightness, shortness of breath, excessive fatigue, or nausea and vomiting. The most frequent symptom, and maybe the only one you'll notice in some students, is coughing. These symptoms may range from mild to severe. For some students, symptoms may go away in 20 or 30 minutes after they stop exercising or take their prescribed medication. For others, the symptoms may last for hours. Students with more severe symptoms may require further treatment of their asthma attack in an emergency department. A healthcare professional makes an asthma diagnosis after taking a complete history, performing a physical exam, and having the student perform breathing tests known as spirometry or additional tests as needed while at rest and perhaps after exercising using a treadmill or a cycle. Once diagnosed with asthma, a healthcare professional should teach the student the proper techniques for using asthma medication and tools, such as an inhaler with or without a spacer and a peak flow meter. The student should receive a written asthma action plan from his or her healthcare provider to be shared with the appropriate school personnel. Triggers are things that cause symptoms of asthma, which can lead to asthma attack or episode. These include allergens, which are things you are allergic to, such as animal dander from feathered or furry pets, cockroach droppings, dust mites, molds, pollen, environmental tobacco smoke or secondhand smoke, chemicals and strong smells, air pollution, weather changes, upper respiratory infections such as the common cold or flu, cold air, strong emotions like crying and even laughter, and exercise may trigger exercise-induced asthma. Managing asthma is a team effort and includes you. Effective communication, medications, and monitoring are the key components to success. Every student with asthma should provide you with their asthma action plan. Your students may need one of two types of medications. The first are long-term control medicines. These are also called controllers. They are powerful in preventing the inflammation associated with asthma, but will not help during an episode. Long-term control medications must be taken for several days before positive effects are noted. They must be taken consistently and as prescribed for maximum benefit. Unfortunately, sometimes students stop taking them because they do not see an immediate benefit from their use. The second type of asthma medicine are quick relief medicines. They are sometimes called rescue medications and provide immediate relief which lasts for several hours. They relax the muscles around the airways and decrease the narrowing of the airways, which contributes to the wheezing, coughing, and tightness of an asthma episode. They are also important as a pre-treatment or prevention before a physical activity or exercise begins. Make sure all medications have the student's name on them and don't allow them to be shared. Some students will use his or her quick relief inhaler 10 to 15 minutes before warm-up as a pre-treatment if prescribed by their physician. They will take one puff, hold breath for 10 seconds, then exhale. Wait 1 to 2 minutes and repeat as noted in their asthma action plan. Some students have been taught by their healthcare professionals to place the inhaler in their mouths while others hold the inhaler opening 2 finger widths away from the mouth. Still, other students may use a spacer or holding chamber which traps the puff of medication until the student inhales it. This ensures that they inhale all of the medication into their lungs. A student may still have an asthma attack even though he or she pre-treated and warmed up. Remember that asthma attacks are never the same for any two students. If your student has one or more of the following symptoms, you need to stay calm and follow his or her emergency plan immediately. Coughing or wheezing, difficulty breathing or shortness of breath, difficulty in talking and walking due to shortness of breath, chest tightness or pain. In an emergency, you should ask the student to stop the activity and sit down, but do not have them recline. Follow the emergency plan on that student's asthma action plan. Ask someone to contact the parents or guardians and call for help while you stay with the child. Call 911 if there is no improvement after 15 minutes or their lips and/or fingernails are blue. After the emergency has passed, follow up with the parents or guardians to prevent future episodes. Discuss with your team if any changes need to take place for the future. Communication is key to helping each student with asthma excel, especially in the situations below, which were noted in a survey of PE instructors. Their primary concerns were students who left their inhalers at home, did not have or follow their asthma action plan, claimed to be experiencing asthma episodes but did not seem to have visible signs. Instructors and coaches cannot risk ignoring any student who reports breathing difficulties, even if the student is perceived to be faking it to avoid an exercise or activity. Each one of these issues must be addressed by communicating with the school nurse and the student's parents or guardians. If you have any questions, please feel free to reach out to your school nurse. Thank you for listening, and I hope everyone has a great school year.
Hi, my name is Dale Furnish, and I am the school nurse at Meridian, and I'm going to talk to you today about Diabetes Level 2 training. All staff will complete Level 1 training on the GCN modules. In Level 2, we are going to learn what to actually do in an emergency. You can help your students with diabetes succeed by having a basic understanding of type 1 diabetes, recognizing the signs and symptoms of low blood sugar, hypoglycemia, and high blood sugar, hyperglycemia, and how to respond to this, and also what to do in case of an emergency. Diabetes is a chronic health condition in which the body cannot use the glucose sugar found in the blood. There are two types of diabetes. The first one, type 1, the pancreas does not produce insulin. And the second, type 2, the pancreas does not produce enough insulin and or the body resists the action of the insulin. What is insulin? Insulin is a hormone produced in the pancreas. It allows our cells to use glucose, sugar, and without it, our body cannot create energy. All students with diabetes will have a diabetic medical management plan, individualized healthcare plan, an emergency action plan, and possibly a Section 504 plan. Many students will be able to handle all or most of their non-emergency diabetes care tasks by themselves. Other students might need reminding to ensure their tasks are completed. Some students require specially trained school personnel to provide or supervise their diabetic care. For these students, a trained diabetic delegated care aide will assist the student when the school nurse is not available. Diabetes requires a balance between exercise and insulin and caution in hot weather. The supplies at school we will have are glucose meter, strips, lancets, and a pen, alcohol wipes, insulin and syringes, and possibly a pump or pen, snacks and glucose tablets, and continuous glucose monitoring. The student with diabetes has some additional needs, such as unrestricted access to emergency snacks and bathrooms, to eat on time and have adequate time to finish their meals, access to diabetic equipment, such as the glucose monitor, and be permitted to check blood sugar levels and respond to the results anywhere, anytime. To be able to contact their parents is needed to help with managing their diabetes. Students with low blood sugar or hypoglycemia may exhibit several different symptoms, such as shaking, sweating, anxiety, dizziness, hunger, a rapid heartbeat, blurry vision, weakness, headache, or become irritable. Please notice that some of the symptoms of hypoglycemia and hyperglycemia are the same. When in doubt, have the student go to the health office accompanied by another student or adult, and let the school nurse that the student is on the way. If a student has symptoms of hypoglycemia, low blood glucose, always give fast-acting carbohydrate. For example, 3 to 4 glucose tablets, 1 tablespoon of sugar dissolved in half a cup of water, 3/4 cups of juice or regular pop, or 1 bag of fruit snacks. Do not give food or drink if a student is unconscious, having a seizure, or is unable to swallow. If that is the case, turn the student to the left lateral position on their side, call 911, and give glucagon if you have received recent training as a diabetic delegate care aide. Remember, we would much rather have the sugar be too high than too low. Hypoglycemia is life-threatening if untreated. If a student has high blood sugar, hyperglycemia, they may present with extreme hunger or thirst, frequent urination, blurry vision, and/or tingling in their arms and legs. Follow the emergency action plan and have the student check their blood glucose. If it is above 250, contact a school nurse or parent immediately. Also, check for insulin pump malfunctions, such as battery low or the date last changed. Hyperglycemia is an emergency if accompanied by severe symptoms. Give nothing by mouth and call 911. Hyperglycemia in school is treated by insulin via vial and syringe, an insulin pump, or an insulin pen. The student or trained staff administers the insulin with a syringe, a pump, or a pen supplied by the parent and prescribed by the student's doctor. Most students with diabetes will start with insulin in a vial with a syringe, and then they will progress to the insulin pump or pen after several months. All needles and lancets should be properly disposed of as biohazard in the marked containers in the health office. Let's review the role of the school staff. First, know the plan. School staff who has close contact with a student with diabetes should familiarize themselves with the student's emergency plan and symptoms of low blood glucose or high blood glucose, and be able to respond appropriately. Provide information such as the emergency action plan for substitutes. 2. Meals and bathroom access. Always allow students to eat and drink and have unlimited access to the bathroom as requested. Eating on time is critical. 3. Monitor. Monitor students after treatment for low blood glucose. 4. Notify. Inform the school nurse and parents of changes in the student's behavior, health, or eating habits. Communicate any changes in the schedule or field trips with the school nurse. And finally, confidentiality. Always respect the student's confidentiality. If you have any questions regarding diabetic care for your students, you can go directly to your school nurse.
This is Chris Drashevsky. I'm the nurse at Pritchett. I'm here to talk to you about seizures. The goal for this training is to help make sure that you feel prepared if and when you see someone having a seizure, and be able to dispel harmful myths about epilepsy and seizure first aid. About 1 in 100 people will have a single unprovoked seizure in their lifetime. 1 in 26 will develop epilepsy, which is the tendency to recurring seizures in their lifetime. Epilepsy is the 4th most common neurological condition. Epilepsy affects more than 65 million people worldwide. Epilepsy is the 4th most common neurological disorder in the United States after migraines, strokes, and Alzheimer's disease. Its prevalence is greater than autism spectrum disorder, cerebral palsy, multiple sclerosis, and Parkinson's disease combined. Most people with epilepsy wonder what caused their disorder, yet in as many as 7 out of 10 people with epilepsy, no specific cause can be found. Among the rest, the cause may be any one of a number of things can make a difference in the way the brain works. For example, head trauma can occur for a number of reasons, including automobile accidents, gunshot wounds, sport accidents, or falls or blows. Lead and alcohol are examples of poisons that can damage the brain. In fact, each year, more than 5,000 people have a seizure caused by alcoholism. The brain of a fetus may not develop properly during pregnancy, or lack of oxygen during birth may damage delicate electrical systems within the brain. It is a myth that epilepsy is contagious. To understand epilepsy, it is important to review the difference between epilepsy and seizures. A seizure is a sudden surge of electrical activity in the brain. It's an electrical storm in the brain. Brain cells either excite or inhibit other brain cells from sending messages. Usually there is a balance of cells that excite, and those can stop these messages. The nature of seizures varies because the lobes of the brain control different behaviors, movements, and experiences. Generalized seizures, these are the easiest to recognize, are identified by a loss of consciousness, muscle stiffening, jerking movements are seen, and they take a long time to recover. Complex partial seizures usually last 1 to 2 minutes, and there may be an aura before, including automatisms such as lip smacking, picking at clothes, or fumbling. The person is usually unaware of their surroundings or may wander. There's usually a start in a small area of the temporal lobe or frontal lobe and quickly involve other areas of the brain, which can wipe out memories, and they can have a loss of awareness. Simple partial seizures are characterized by motor or sensory seizures, autonomic seizures that can cause changes in any of the senses, cause changes in the part of the nervous system that automatically control bodily functions, can be psychic changes that change how people think, feel, or experience things during them. Absence seizures are characterized as lapses of awareness, sometimes with staring. They begin and end abruptly, and they only last a few seconds. These are more common in children and can be brief. They are hard to detect, and they can also be accompanied by some movement, including blinking, chewing motions, or hand gestures. Only a doctor can say for certain whether or not a person has epilepsy, but many people miss the more subtle signs of the condition and therefore also miss the opportunity for early diagnosis and treatment. Learning about epilepsy early and working to control seizures can often help to minimize the impact of the disorder. The symptoms listed on this slide are not necessarily indicators of epilepsy and do not include all of the symptoms of seizures. These symptoms may be caused by some other unrelated condition. However, if one or more is present, a medical checkup is recommended. For a majority, perhaps as high as 70%, of people with epilepsy, seizures can be substantially reduced or completely controlled and may have little impact on the quality of life. For the remaining 30%, epilepsy is truly disabling, marked by frequent seizures, other impairments, memory and other cognitive effects, and a dramatically reduced standard of living. Long-term anticonvulsant or anti-epileptic drug therapy is the major form of treatment. Approximately 20 anti-epileptic drugs are currently in use. Most people are treated with one of these drugs. However, some may require 2 or more for best control of seizures. Surgery may be tried when medicines fail. Most often, surgery is used when the brain tissue causing seizures is confined to a small area of the brain that can be safely removed without damaging personality or function. Some people have good luck of a ketogenic diet, a special high-fat, high-calorie diet. This may be tried in children who do not respond to standard medications. VNS, Neurospace, and RNS devices may also be used. Lifestyle modifications center around identifying factors that trigger seizures and avoid them to minimize the potential for seizure. Over time, many people with epilepsy become aware of certain activities that may trigger the seizures. Avoiding these triggers may decrease the frequency of seizures. The most common cause for a breakthrough seizure is missed medication. It is estimated that half of the people taking medication for epilepsy don't take it as prescribed. Other triggers include stress and anxiety, exertion, or fatigue or dehydration, lack of sleep, and hormonal cycles in women. Some individuals have photosensitive epilepsy. If so, flashing lights or alternating sun and shade may trigger seizures. Use of alcohol should be discussed with the physician, and use of street drugs should be avoided. Even some over-the-counter medicines can be avoided when taking epilepsy medications, except under the advice of a physician. Just as with the causes of epilepsy, triggers are often not known or not present. It is important that children and adults with epilepsy not be blamed for having a seizure, nor should they be prevented from participating in a full range of activities unless they or their parents or their physician requests an accommodation. Now I'm going to talk about the focus first aid for seizures. When you think of helping someone who's having a seizure, what is your first instinct? A student who has a seizure disorder will have a seizure action plan in place, which will give you specific details. If you see a seizure starting, attempt to prevent injury by easing the person to the floor. Keep hard, sharp, or hot objects out of the way, and watch the time. Turn the person to the side if possible to allow saliva to drain and to prevent choking. Do not restrain the person. You may also place a soft towel or item under their head if the floor is hard, or use your hand to cushion their head. Do not give fluids or food during or immediately after a seizure. Loosen restrictive clothing or equipment if needed. Observe for injuries, the length of the seizure, skin color, and their breathing and any difficulties breathing. Call 911 for any seizure lasting over 5 minutes. Call 911 for any first-time seizure, and call 911 and start CPR if there is no breathing after the seizure. And call 911 for any injury caused during the seizure. When the seizure is finished, the person usually is sleepy. This is normal. Place the person on their side in a comfortable place to rest, where they can be observed. Tell the person where they are and reassure them. Notify parents and the school nurse of any seizure. Usually the students will go home. And document all seizure activity. Discuss this documentation with your building nurse. If after this presentation you have any questions in regards to seizures, please see your building nurse.
Hi, my name is Dina Hinkle. I'm the nurse at Tripp Elementary School, and I'm going to be talking to you about life-threatening food allergies. Anaphylaxis is a severe and potentially life-threatening allergic reaction to a substance. The body recognizes a substance as harmful and releases histamine and other compounds that cause swelling and additional symptoms. Anaphylaxis can occur within seconds or minutes or even up to several hours after exposure to an allergic trigger. The causes of anaphylaxis include insect sting, food allergy, drug reaction, latex, rarely exercise, and unknown causes. The main strategy for anaphylaxis is prevention of exposure to known allergens. The most common causes of anaphylaxis in schools are food allergies and insect stings. Any food can cause a food allergy, but 90% of reactions are caused by milk, soy, peanuts, tree nuts, shellfish, fish, eggs, and wheat. Sesame is also a common food allergen, and Illinois was recently the first state to mandate laws about identifying sesame in food products. Insect stings caused by honeybees, wasps, yellow jackets, hornets, and fire ants are also a common cause of anaphylaxis in schools. It is estimated that 7 to 8% of children have a food allergy. About 40% of children with food allergies have had a severe allergic reaction. Several studies have shown that teens and young adults are at the highest risk for fatal anaphylaxis. The best way to prevent anaphylaxis is avoidance of the allergen. In school, this may include precautions such as elimination of certain foods in classrooms, separate allergen-safe lunch tables, no eating on the bus, no sharing foods or snacks, and amended procedures for celebrations at school. Symptoms of anaphylaxis include swollen lips, tongue, or eyes, severe itchiness, rash, hives, nausea, cramps, vomiting, diarrhea, congestion, a hoarse voice, difficulty swallowing, wheezing, continuous coughing or difficulty breathing, dizziness, fainting, or loss of consciousness, and mood change or confusion. The highlighted symptoms are the most concerning. Please recognize that many of these symptoms are vague and are present with a variety of illnesses or general complaints. Also, be aware that younger children may present differently than older children and may say things like, "My mouth feels spicy." Each student with a life-threatening food allergy will provide a food allergy action plan, completed and signed by the physician and parent. A copy is kept in the health office with the medication and will be provided to the teachers who have contact with the student. The school nurse will write an emergency action plan and distribute a copy to each teacher who has contact with the student, and the copy should be available in the substitute plans. The school nurse will write an individualized health care plan, which outlines the provision of student health care services intended to achieve specific student outcomes by the school nurse. Students with life-threatening food allergies will usually also have a Section 504 plan, which will be distributed to teachers who have contact with the student. Administer epinephrine anytime you suspect a severe allergic reaction or anaphylaxis based on symptoms. The symptoms of anaphylaxis can be unpredictable and progress rapidly. When in doubt, administer epinephrine. Always call 911 when you administer epinephrine. The two most common auto-injectors are shown here. The EpiPen epinephrine auto-injector in the yellow package is geared towards adults and used for persons weighing 66 pounds or more. The green package is the junior dose and is used for persons weighing less than 66 pounds, in about third grade. If there's any doubt, give the adult dose. The Auvi-Q epinephrine auto-injector is pocket-sized, has a retractable needle, and comes with voice instructions. The blue injector is the smaller dose for children weighing less than 66 pounds, and the red injector is the larger dose for children weighing 66 pounds or more. The physician is responsible for prescribing the appropriate dosage for the student. Remember, antihistamines and asthma inhalers do not treat anaphylaxis. However, students with asthma are likely to have a more severe allergic reaction and may have an inhaler to use to assist with anaphylaxis symptoms. If in doubt, it is always better to treat than to delay. Mild side effects of epinephrine administration may include an anxious feeling, a fast heartbeat, nausea, headache, paleness, or shakiness. Let the person know that these are common side effects and will go away. Remain calm and provide reassurance. To administer an EpiPen epinephrine auto-injector, remove the auto-injector from the container, pull off the safety cap, swing and firmly push the needle tip against the mid-outer thigh. It is okay to administer through clothing. Push the injector into the thigh until you hear or feel the click. Hold in place for 5 to 10 seconds. Remove the injector and massage the area for 5 to 10 seconds. Keep the device until emergency medical personnel arrive. Give the expended device to EMS personnel or discard in a sharps container if that is the direction. Although we are fortunate that EMS in our area is close by, a second dose may need to be given if symptoms do not resolve or progress prior to EMS arriving. To give an Auvi-Q auto-injector, pull the Auvi-Q from the outer case, firmly pull off the red safety guard, place the black end of the Auvi-Q against the middle of the outer thigh, through clothing if needed, press firmly until you hear the click, hold in place for 5 seconds or until the device indicates that the medication has been dispensed. The Auvi-Q will still deliver the medicine if the voice instructions are not working, and remember that both devices have the instructions printed on the container. So if you need to review the instructions prior to administering the epinephrine, you can do so. In the case of a suspected anaphylactic reaction, call the school office or send 2 students or an adult. Tell them to call 911 and to bring an EpiPen. Give the exact location of the student. Administer the epinephrine auto-injector if indicated. Stay with the student until EMS arrives. Keep the student upright if they are having trouble breathing. Lay the student down with their feet elevated if they are pale. If they are vomiting, roll the student to their side. Give a second dose in 5 to 10 minutes if symptoms do not improve. If breathing stops, start CPR. Complete any documentation needed that is related to the incident, and contact the school nurse for documentation forms and further information. If you have any questions related to anaphylaxis or food allergies in school, please contact me.